So, adolescent programming matters is a challenge in Kenya today because of, let me use a word like the draconian policies, the legal framework, the policies we have that bar us from service delivery. I'm giving an example like you're giving an implant in Kilifi, for example, to a 16-year-old. You're giving comprehensive sex education to a 13-year-old in Seme or Ongola. So, do you have challenges? Do you face challenges with these policies, with these laws? And are there deliberate efforts to mitigate the risk because it is cutting across? And the other one is not a question. I am very much interested in global leadership with local solutions, and what Dr. Nelly said, customized interventions. So that makes me understand that there's room in your programming to accommodate what comes from the community, what comes from the adolescents themselves, but even as we look into that, accommodating what the adolescents are doing, and as we motivate them, particularly to A360, putting a spot on that. When you reward the adolescents, don't you think that is conflicting the tokens that we talked about? Because we're talking about sustainability. When a project is done completely out of Kilifi County, and I am implementing Youth for Health, which is funded by the European Union, and in the framework there is no rewarding, there's no tokens. So, when I come at Marafa dispensary, where you were yesterday, and you rewarded the youths, and my project is not allowing me to reward the youths, those conflicts, how do we work around that so that projects do not, so that we don't buff other projects from implementing smoothly, while what we did it innocently and with a plan and with some donor approvals. So that is my question and my comment, but I must say that you guys are doing good jobs, and I'm happy that I'm picking that we can partner, because our project in Kilifi, Kwale and Taita Taveta, funded by European Union, is implemented by Maristops, DSW, and CSA. And I can pick some things which you are doing, which you can leverage. And the partnership can be very strong. So it's a thumbs up from my side, on behalf of Maristops, and looking forward for partnerships. Please do find some time to respond to my question.
Thank you very much. My question would go to Dr. Nelly. First of all, I was very excited by your talk, and it kind of resonates with the experience that I go through a lot in my practice. So you hinted a lot about the adolescents and children in transition phases. I want to draw my question towards the children who are transiting pre-pubertal to pubertal. Because, for example, around that time they're starting to know their bodies. They are starting to get attracted to girls, get attracted to boys. And if they have HIV, prenatally acquired, it's around the time they start now understanding what exactly HIV means. And that is around the time when they are actually starting to get hormonal changes and physical changes. And in my experience, a few times I've tried to talk to mothers when they come to my clinic and to my practice. You ask them, so, has your girl started to get menses? And the girl is 9, 10, and they feel very offended by those questions. I ask them, does she have a boyfriend? Is there a boy she has a crush on? And everyone seems not to want to talk about it, and they want to push it to the teacher at school. So that has been my experience with the girls, and I'm wondering, in your practice, how has it been for you, and what is the mix when it comes to the boys? Because it seems to be a different ball game. Everybody seems to be talking about the girls when we talk about SRH. And as an advocate of the boy child, I'm wondering how much are preparing the boys to respect the girls and to understand what the girls go through as well. Thank you.
I also have a question for all of them. I'm also an advocate of the boy child, and my question is, where is the space of the boy child today? Because we are all gearing towards achieving sustainable development goals, and we have SDG number 5, which is gender equality, and SDG number 10, which is reduced inequalities. And for example, we have a global organization like UN Women, which stands for championing of gender equality. But why don't we have UN Men? Why is the conversation about SRHR where is the voice of the adolescent boys and the young men? The ABYM. A lot of times we always speak about AGYWs, adolescent girls and young women, but where is the space of the adolescent boys and young men? And just a question, yearly we always celebrate the International Day of the Girl Child, International Women's Day, but do we know that we also have the International Day of the Boy Child, which happens in May 16th every year, but we don't celebrate the International Day of the Boy Child, we don't celebrate even the International Father's Day, which happens yearly. It is not as vocalized as for women. And so I would like us to start redirecting the attention and the focus also to the boy child, because even the Bible says in 1 John 3:16, it explains of John 3:16, whereby it talks about Jesus or God loving the world and giving his son for the salvation of the world. But 1 John 3:16 amplifies that and says, as he loved us and gave his life for us, we ought to give our lives for our brothers also. And in this aspect, we don't even have to die, but just giving our time, redirecting our energy and our advocacy for the boy child. And that is my question and my plea.
We'll take those first, then I'll go to the other side, the last one.
So I'll start with the first question on policy. I am implementing on the ground family planning, contraception, and the approval is different based on the context you are implementing. If you call it contraception, you will call it child spacing, you will call it family planning based on the context. But we have to agree that our policy environment is very confused. It provides room for both what we are doing and also against it. And looking at first example is our constitution. It says under the Bill of Rights, everyone has a right to health, including reproductive, everyone. So it does not say that adults, children, and so on. But again, we come back to the reproductive health policy that was launched last year that recommends on parental consent for minors. And the policy categorically says that it is not in the spirit of the policy to promote abuse of children. But if you look at Kimberley, the policy is recommending. The policy is not saying it is a must. So where does that leave us? That leaves us at the mercy of county leadership. So because health is devolved, each and every county normally has a way of interpreting these policies. Because some of the counties, because the police has recommended parental consent, they will say that parents must consent. For others, they will say that it's a recommendation. So we are normally in the mercies of the goodwill of the county leaderships during our implementation. That is the challenge. For us, as a 360, I want to mention that the exact county, but one of the counties really fukuza sana. And it is one of the counties with the highest rate of adolescent pregnancies in the country. In the cohort of 3 in KTHS 2014, currently the state of 5, but they wanted to focus on saying we don't have teenage pregnancies here, we don't have marriages, and the same county as FGM. child marriages. So those are some of the challenges that we are experiencing. But I would say that there is opportunity because, as Dr. Bosire said, the SRHR policy is still underway, and those are the issues that are there. And it's because I normally say that even most of us here are medical professionals, we don't live our cultural beliefs and religious beliefs when we go to the facility or when we enter boardrooms. Instead of coming into a boardroom for a discussion as a doctor, you come in as a staunch follower of a certain church and a certain bishop. So those are some of the challenges that are there. So we don't write policies in the spirit of the people, but in the spirit of our beliefs, which sometimes do not work for everybody. Besides that, on the other question on payment for adolescents, I am a believer of meaningful adolescence and youth engagement. And one of the pillars for this is youth compensation. And just drawing into some of the policies that are going into compensation, we have, for example, the tiered amendment. If you've ever implemented with any usage funding, it is compulsory for you to take that course. You know, some of us who have been in programming knows it. And it talks about compensating, for example, people for family planning. And the same principles goes into research. What can you compensate for, and what can you compensate for? So for me, we don't compensate adolescents for taking up contraceptive methods or going to the facility. But where an adolescent has mobilized other adolescents to come to the facility. When we pay CHPs for the same job, why can't we pay the adolescents when they're doing the same one? So it is compensation for work done. If people take their time to do our job and we are paying other people for the same job, then we also need to pay these guys. But we do not offer tokens for adolescents for getting services. That is unethical and it's not sustainable. And the other principle to it is that economic empowerment and sexual reproductive health go together. One of the problems, one of the challenges, especially for rural adolescents and marginalized, is poverty and lack of resources. Adolescent girls go through these several problems to get even sanitary towels on a monthly basis. So again, if you compensate them for this work, it goes a long way in their life beyond just what you've done. And then finally, on the engagement of the wage child, for us it's coming up because again we agree that we focused a lot on the girl child as a program. But again, the challenge we have is with funding. So donors give us money with specific objectives, looking at specific individuals. You receive money exclusively for young people under the age of 24. And there's really very little you can do for other people beyond that age cohort. You receive specific money for women. And you realize that convincing the donor to use this money to engage men is a problem. And that's, I think we need to, in terms of boy-child engagement, and especially for most of these programs that we run, I think we need to make more noise on the frameworks for funding. Because if the funding mechanisms can be more flexible and more adaptive, then we can be able to engage the other genders. So, thank you.
Thank you, Collins, for that. I'll respond to the first question on policy. Yeah, it is just what you said. It's really great. You can navigate this way and you can also navigate the other way. What we do in our reproductive health advocacy, reproductive and sexual health program for Kenyan teenagers, we tailor-make training materials that will target both the male and the female, and we give them information as far as the Constitution of Kenya allows us. So when it comes to, let's say, the topic of contraception, the further the Constitution allows us is how far we will go, and we will tell them this is what you need to know, and if you want to seek services on contraception or whichever name that we will call it based on the context, then you can access it there. Then on the matter of the space of the boy child, indeed, even if we just remove this from an SRHR conversation, we look at it from a society point of view. Society is slowly degrading because we are losing the value of how society is structured. Women empowerment has been really good. It has been important because women from marginalized communities, women from what areas are able to become who they are. But the challenge is these women are trained to be empowered women, but the men who will be their husbands, the men who are their brothers, the men who are whoever they interact with daily are not empowered to not just deal with this woman, but live in the same society with this person. So there's the challenge of funding. But then again, as I was looking at it and looking at how we can promote inclusive programming, the same thing of thinking globally and act locally. While the donors may not will give us funds for specific things, one of the things we talked about was how are we able to domestically fund our own initiatives. So if we look at strengthening domestic financing for reproductive health services and whatnot, then we will be able to include the boy child, and not just include him because it's a token, because the boys have made the noise. Because even if you look at adolescent and youth-friendly services, most of these things are tailored to women, but we don't look at men as also clients for these services. So how are we able to act locally so that we ensure that our society does not tear down because of that? The other thing that is proving to work is the population health and environment approach in development. When you go to your policy maker and tell them we want money for SRHR alone, they will not look at it as a priority. But if you tell them we want money for this program because it is related to an environmental program we have in the county, and this is a population issue, if you're able to bring the three together, then you're able to tie most of these sustainable development goals, and when you're funding, you're able to fund across. And this has proven as a way in which healthcare people especially are able to get funds for that. So population health and environment, just to create that inclusivity of the boy children is one of the approaches that we can use. But also ideally, I charge that responsibility to you as a person. What can you do wherever you're seated? We are never too limited to say, I'm just a student, I can't do anything. What can we do to ensure that our society does not degrade our boys as the women come up?
Thank you. I think I will start with addressing the issue about policies and regulation. One thing I learned is that a lot of people know we have laws, they know we have policies, we have their regulations, but they don't understand them, or they haven't taken the time to read them. Even the lawmakers who make them. And that has been an interesting revelation for some of the work I have been doing these past 2 years, where we focused on policy advocacy for our actual lawmakers. And just sitting down with the Parliamentary Health Committee and asking them, when you are allowing the passage of the amendment of the Children Act to take away evolving capacities in decision making, did you think it through this perspective? Becomes a problem. So what we have is a society that is still very uncomfortable about having conversations about sex. And when you take this away from sex and look at the bigger picture for health, it becomes an easier conversation to sell. So the challenge is that when SRHR advocates sit in the room, they really push this SRHR agenda as if it's an independent entity. And by saying, can we broaden the picture and look at it as healthcare? If we look at it as healthcare, then we are able to be more convincing. And it is more, and that's why we said even when you see some of the work at Thriving Teens we're doing, we're looking at SRHR, but we're looking at what no one is going to contest. If a child has a chronic disease, they have a chronic disease. You will not bury your head in the sand about how their chronic disease disadvantages them in access to some of these things. So it becomes a broader perspective. Remember also what I was talking about, that when we talk about SRHR for the youth, we must be able to look at the bigger picture and the fact that this youth is tomorrow's adult is in a few decades the old person in the community. How does today's conversation impact the next 50 years? If we can't have that, then our policies will be very self-centered and literally will reflect who was in charge when the policy was made, which is the challenge that we are actually struggling with right now. So for instance, we were not able to have a reproductive health policy, the Ministry of Health, for 7 years because we could not agree. The last one expired in 2015. We finally signed one into law in 2022, but we're not comfortable with it because it's the mother reproductive health policy. So the adolescent sexual and reproductive health policy will have to align. So we have actually people in court right now challenging that act so that it can be withdrawn and be redrafted appropriately to now give room to the SRHR one to make sense. When it comes to policy advocacy, I tell people when I train them, hakuna uvivu. You can't stop talking about what is required. So the conversations must never stop. You have to talk people's ears off to a point where they agree to consider it. So while we are having this experience where counties running them out, we are having the opposite experience where counties say, we can't even adopt those policies they tell us because they don't consider the challenges we have on the ground. So for them, every youth who shows up is actually given a contraceptive. And as we say, the policy environment is so confused. You set a policy, you actually have its indicators, you actually expect reporting from the service, the implementers of these policies, which is at county level. You even provide for them to give you those statistics. Then you come and tell them it's illegal. So one of the counties told us, you want us to account for our FP. You actually want us to collect data about how old our FP users are. So when you tell us we should not give them contraceptives because they did not have consent, you want us to stop reporting. And yet we are saying we need policies that are evidence-informed. So if we start by collecting incorrect data, how will it inform appropriate policy development that is responsive to the population? So it's just having that consistent effort, and we have to appreciate that you cannot do it alone. It cannot be a one-off affair. We had fantastic progress in SRH policies between 2012 and 2017. The rain began to beat us in 2018, and the problem is that the policies that have been put in place in that period have taken us 2 decades back. So we have no choice. We have to appreciate we've been put in the hole, and we have to start clawing out. Advocacy, advocacy, advocacy. We cannot stop. It doesn't matter. So we have to really be very focused and remain on the path and know that ultimately we have to do this for the common good of everyone. The other one is the pre-pubertal to pubertal transition. So one of the challenges we've had is that pediatricians are not talking to adult workers. And that's the challenge. Because you treat a child as a child, and in Kenya, in a public health facility, when a child is 13, she's transitioned into adult. We actually do not have adolescent well-being clinics as a standard in the Ministry of Health structure. That can happen in private practice like Gertrude's, which actually will see them even up to 21. But in the public sector, we've asked these questions. And it's in the basic little things like, when you are 12, you're admitted in the pediatric unit when you're sick, and when you're 13, we put you next to an 80-year-old man. The child can't even adjust. And we have had these conversations. This is patient-centered care. Where is the adolescent unit? Where is the transit? You know, they look very small until you are the one whose child is sleeping next to somebody who's 90. And they're looking at you like, I want to go home. I want to go home now. You understand what we mean? So it is, and that's why I keep saying, the impact on SRHR is actually beyond what we look at narrowly as SRHR. Must be looked at with the bigger lens of healthcare, patient-centered care. And my patient is an adolescent, and their needs and requirements must be honored in line with what they require. So it then helps to start building transitions. It is interesting that parents will not even know to take a doctor to an RH practitioner unless it's a problem. And that's one of the biggest challenges we had when we were now introducing the HPV vaccine, because we were giving it to the child sitting at the cusp of not being a child, but also not being exactly. So the parent is not understanding this healthy chap running around. You want me to stop my business for a day to go queue at a health center for them to get a job? For what? They're not having sex, it's not necessary. So we didn't think it through. And education is everything. So for your prepubertal, you are challenged with information dissemination and the capacity building. It's not in the child. You have to start with the parent. The parent has to appreciate what their child is going through, so that they become your partner in care provision. So if these conversations have always been awkward, it's our job to unawkward them. And that must be irrespective of the child's gender. So that the child is more comfortable. We must be able to say, you brought your child to me, would you give us a minute for me to have a conversation with your child for just a few minutes, then you can come back. You're teaching the parent to give the child agency. Because if the child has no agency, their voice will never be heard until they exit the care of their parent. So it takes a lot of building trust and building commitments, but we really must focus on health education for the parent. Because as long as that person is on board, you are going to be fine. But if they are going to look at you as you have stepped all over my space, then we are really going to have a problem. The last one is the space of the boy child in SRHR. And just what is said, programming will always focus on what is perceived as a problem. Are we generating data that shows that SRHR among the men and boys is a problem? Right now, if you go to any data that is looking at adolescent health issues, when they classify them in line with gender, what is topping for the boys? What's the highest reason for them needing health care? It's always trauma. Trauma. They're getting into accidents. They're getting into injuries. They are playing contact sports. They are in road accidents. They are falling off their bikes. That's the leading reason why they're actually in the health system. What is it for the girls? It's also trauma until you actually segregate it to the developing world. And then it is maternal health issues. So the moment you see those figures going that way, the people who fund the programs are going to focus on what looks like the thorny issue. But we haven't said that trauma in boys is a problem. So maybe we need to use that as an entry point and focus what is the data saying and how can we use that data to attract funding for the boy child under the areas that are viewed as a problem, and then work towards expanding that umbrella and including SRHR. Otherwise, we are not going to be very successful. It does not mean that there is no problem, but we also must start making SRHR care agenda. It is a human issue, not a male or female issue, because it takes two people to engage in SRH. So if we do not look at them as partners, and it's just as basic, if you're going to be a healthcare provider, you need to be the one to start fixing your own mindset. Do you make it a habit to ask your pregnant patient, where is your part? Because if you can't make that a normalization, it's going to become a challenge even when you're discussing contraception. It's going to become a challenge even when you're talking to them as parents on the transition of their 9-year-old. So always try to say it is care irrespective of gender. And when it's patient-centered, it then is community-centered. It means when you're in the room as a patient, you didn't come alone. You are surrounded by a team that actually informs and contributes to decision-making with regard to your health.
Thank you, panelists. I think due to time, we are not going to take any more questions, but